Hello and welcome back to Basically EMS, joined by my man Wade today, and we are going to talk about bleeding. With bleeding, it's not a super complex concept, right? It's pretty basic, but either way, I think as always we need to kind of come back and talk a little bit about the A&P side of things.
Right. Yeah.
So let's start with a little bit of anatomy, and this is just going to be the anatomy essentially of the cardiovascular system, right? So if we're talking about blood, it's really important for us to remember the heart and the lungs, right?
Yep.
So heart and lungs are going to be important here, right? We got to remember the function of the heart is to send the blood around the body, essentially, right? And the function of the lungs is to exchange those gases. So exchange that CO2 and that oxygen, because we need the oxygenated blood to go to the body systems, right?
Yeah, we need that big fancy P word, perfusion.
Perfusion. It's kind of like, you know, there's one takeaway as a student from all of EMT course that you need to have is that perfusion is king. That's all our body is trying to maintain homeostasis by maintaining perfusion, right?
Right. It wasn't even until I was done with medic school. I was actually running a call with Justin, and he's like, everything you do in this field comes back to perfusion every single time. And that has been burned into my brain every time because it's like, I bet I can think of a time it doesn't, and I've been skunked. So, for sure, a very important concept.
Yes. I mean, at least specifically for EMS, maybe not healthcare in general, but for EMS, right? When we're talking about emergency medicine, keeping people alive, perfusion is the be all end all. We also, when we're talking about kind of the A&P of bleeding, it's really important, and I harp on this all the time, but remember the perfusion triangle, right? So we talked about kind of the basic anatomy that's going to be, important for bleeding, heart and the lungs, and then obviously the vessels as well.
Right.
But talking about, that perfusion triangle is really important because of perfusion, right? So all three of those portions of that triangle need to be functioning for perfusion to be maintained.
Right. And so another way of thinking of it, right, we're talking heart, lungs, vessels, pumps, pipes, fluids. If you're someone who, I think it really opened up when I was doing, or at least for me, when I was building my sprinkler system a couple of years back, that it was like, oh, this is kind of the same thing because I was using a pump system, irrigation, whatever. But if you're someone who's like having a hard time putting that together, think about when you've worked on your sprinklers, right? Is this something where, okay, we've got water leaking. Is this because I don't have enough pressure in the pipes? Is there something wrong with the pipes, or is there not enough fluid? And it's the same thing in our body, right? We got to keep that same circulation flowing so we can keep perfusion high so we can hopefully have better outcomes.
Yeah, if there's not enough pressure in the system, going back to the sprinkler thing, right? Your sprinklers aren't going to spray because there's not enough pressure within the system to cause that spray. And so that's what our body's trying to do. Just with the perfusion triangle, we can make a couple changes that maybe you couldn't in your sprinkler system, right? So the heart can beat faster to increase the pressure within that system because more beats equals more pressure. The veins and arteries can get larger or smaller depending on what's needed. And then what we're talking about is going to be that fluid, right? That blood.
Right.
So we can increase blood volume, but that's not a fast process. That's a slow process.
And that's not a basic scope thing either.
No, yeah. Treatment-wise, basics aren't going to be able to fill the tank, as we like to call it, with saline or blood products or whatever you carry.
Pressors or whatever.
Yeah. But it's still important for us to remember that we can lose blood from that system, right? So bleeding is going to affect that portion of that perfusion triangle.
Right. And lack of circulation looks different too. Everyone, when we talk about bleeding, obviously we're talking external bleeding for the most part. But, presentation of poor perfusion looks different, right? Like if you show up and they're like, I'm having chest pain and I'm getting lightheaded and passing out, that's still a pump pipe fluid issue, right? You just got to kind of delegate which one. And it's going to be tougher. At the basic scope, there's limiting factors to that, obviously. But it's still something to consider, right? It's not all bleeding that we show up to, internal or external, is going to look the same. And then not every perfusion problem is going to be bleeding necessarily.
Yeah, exactly. There's other things that would affect the fluids for perfusion or whatever. One of those three things in the perfusion triangle.
Right.
Being a little more specific with the A&P within that perfusion triangle, we've got our heart that has two different sides and then four different chambers, right? So right and left atrium ventricle, right and left atria and ventricle. There we go. There's a 4.
Yep.
I was not going where I was thinking I was going with that one. And so we always need to remember the right side comes first. So if we're thinking about the perfusion triangle and all this, the cardiovascular system as a circuit, the first part of it we typically think of as that right side of the heart.
Yeah, we're reading it from left to right. Patient's right, but our left.
And then there down to the lungs, and then left side of the heart and out to the body. Right, really important to remember that.
Yeah, it's important to remember too. When it comes to the left and right, they both have different jobs. Right sends blood to the lungs. Well, backtracking, gets deoxygenated blood from the vena cava to the lungs. The left side receives from the lungs oxygenated, sent forward via the aorta at that point. But remember, it's still a two-paired pump. Even though the right and left side are delegated to their one job, the top's still going to pump together, so both atria, bottom's still going to pump together, both ventricles.
Yep. And then as it gets pumped out of the heart, it goes out to the circulation. So those veins and those arteries. And those are pretty basic. It's going to be arteries first. And then I like to think of the circulatory system kind of like as a tree. And so your arteries are going to be your trunk essentially. And then you've got your arterioles where it gets smaller. And then it's going to come down to the capillaries, which are like the leaves. And that is where that gas exchange happens.
Correct.
And then we come back venules to veins to the heart, right? So got to remember the breakdown of those different things, because a venial bleed is a lot different than a big arterial bleed.
Right.
There's the amount of blood circulating depending on where it is in that system is very different.
Yeah. And then, remembering a big confusion that I've seen in my own students is remember that gas exchange happens everywhere. You have capillaries all over your body. The big, when we teach this a lot, it's going through the pulmonary circuit. So it's going to be that gas exchange via the lungs. That same gas exchange happens all over the body in a more systemic effect, dropping off oxygen to the cells that need it, pulling away that carbon dioxide and taking it away.
Yeah, it's just reversed essentially. But yeah, same process.
And I think a part, that we'll probably touch into a little bit more, but the actual anatomy of the blood and part into the physiology is, remember the different cell components of the blood. The red blood cells in particular, if you're planning on taking your NREMT, they're going to ask you, what does an SpO2 monitor read? And most people say, it's the oxygen in the blood. And that's wrong every single time. It's going to be measuring the hemoglobin, how full the hemoglobin on our red blood cells is. That's why things like carbon monoxide will throw off an SpO2 reading, but that's non-viable, non-usable air.
Yeah, it's the saturation of the hemoglobin, the percentage of the saturation, not with oxygen, just like you were saying.
Yeah.
And carbon monoxide specifically is scary because your red blood cells have a higher affinity for carbon monoxide than they do oxygen. So, that's a point I always drive home. That's really good. Remember that if you're a student. Not oxygen saturation of the hemoglobin, typically with oxygen, but not always, right?
The way I think about it too, when if you're having a hard time, why does CO have a higher affinity? Nature, if you've got any chemistry background, nature's kind of lazy. It's going to find the easiest, most effective methods. So if you look at oxygen we breathe, O2, versus carbon monoxide, 1 oxygen, the hemoglobin's going to look at it and say, I'd rather carry one of these things than 2. It's way less work. So I'm going to grab onto that instead of the 2 double up the work, And so just keep that in mind, right? There's different, and that's CO is just one of who knows how many examples of gases that can do things, do that to us. But just keep that in mind. That's why it's got that higher affinity.
So your body is like your friend when they come over to help you move, that they're going to be like, I could take both of those things, but I'm just going to take this vase, this one small thing.
I'm not going to carry that dresser. You can definitely carry that. I got the box of clothes.
Yeah, the O2 is the couch. Yeah, and then the CO is the small box of clothes.
Yeah, I can handle that. That's my speed.
For sure.
No amount of pizza is going to get me to pick that couch up. Sorry, buddy.
What else? What other components are there of blood?
Yeah, so red blood cells, we just talked about, big one. We got your white blood cells. Those are kind of the enforcers, I think, of in the blood. They're the ones that fight and kill the bad bugs, germs that get into our body there. kind of part of our immune system, one of the first portions of our immune system. They also kind of pull the dead bodies away. Kind of got the medic job a little bit to a degree. And then we have the platelets. So platelets are responsible for clotting. And then we have our plasma. So think about your cells, your white, your red, and your platelets. Those are all kind of free-floating little individual pieces. The plasma is what makes your blood wet. So that's the, quote, vehicle that carries the cells throughout the body. That's why when people donate plasma, they can separate the two and still put the cells back in. The cells are, if you've ever donated, look a little clumpier. It's like thicker. But yeah, that's because the plasma is getting pulled out.
Mm-hmm. So for the purposes of today, platelets are kind of what we really need to be concerned about, right? If we're talking about bleeding and staunching bleeding and stopping bleeding, it's going to be those platelets that are important.
Correct.
So talking about stopping bleeding, right, there are a couple different factors that are important because we need to be able to clot so we can stop that bleeding, right? And so there are things that can affect that for us to be aware of. Intrinsic factors with the patient, like a factor 9 deficiency or some sort of hemophilia, something like that. Or another big one that I think we sometimes find it easy to forget, especially when we're new, is something like blood thinners are going to make a big change in that too.
Yeah. Yeah, if you're unfamiliar with those, that's worth your time to look up things like Eliquis and Plavix. Just make sure you have a general understanding of what that list is, even if you don't understand what they do necessarily to the full extent. Just know that's a blood thinner. If they're bleeding, we got problems.
Yeah, and it's always important to, I feel like, at least in my experience, most of the time people are on blood thinners, it's usually because they have AFib. That's probably the most common diagnosis that will lead to a patient being prescribed blood thinners. So if you have a patient who is bleeding and you see in their history, they tell you they have a history of AFib or they have an irregular heart rate, you need to be thinking, is this patient on blood thinners? Because that can take a mild bleed for most people and make it a life-threatening bleed if they are on blood thinners.
Right. Or even like stroke history is another one that people will commonly have prescribed. Double check. The history solves the mystery, and especially in our older folks, you ask them, what do you take? I don't know. It's a big, long list. Sometimes the history, just finding out, okay, they have AFib. Oh, they had a stroke. This is a high likelihood. And sometimes with blood thinners, it's pretty obvious with some folks because you'll see a bruise on them that's just gnarly. Like, what'd you do? Like, I bumped into my couch on the way by and it's, a big old 4-inch in diameter bruise. So just keep that in mind, right? Pay attention to your surroundings and pay attention to your patient. Not everything they don't have to necessarily tell you for you to find the issues. Yeah,
and they won't always tell you.
Yeah.
The amount of patients I've been on that, like, what kind of medical history you have? Oh, I think I'm pretty healthy, nothing. And then do you take any medications? They hand you, like, the 6-foot box of medications, like, poof.
Right.
And you're like, there's 42 different things in this box. What do you take these for?
Right.
Oh, well, I had high blood pressure, but I take high blood pressure meds, so now I'm better. That mentality can catch you out.
I don't know if you've noticed this, but like, where do you think they find those laundry baskets that are so small? They're always like full of medications every single time.
I mean, I don't know. I know we have some. I could ask my wife if you're really that interested. We have some for like drawers, like drawer organizers. Yeah. So maybe something like that.
You got your meds,
but I know
organizer.
I'm not that old, dude. I'm not 40 yet.
Not yet. Yeah.
But yeah, it's very. I feel like it's very specific. Like they all have the same little like
off blue
plastic, like kind of looks like a woven basket that they all carry them in. Maybe like it just comes with your AARP membership. It just comes in the mail. Just like, oh hey, you turned 65.
The card's taped to the bottom.
But yeah, so be really aware of those things when we're talking about patients like blood thinners and medications that could affect it. There are other things that are going to be affected, right? Like, or that could be effective when it comes to stopping blood. The patient's ability to change, to like clamp down externally with their veins and arteries is going to be a big part of it too, right? Like if we have a bleed and the body's going to want to make those veins and arteries smaller to reduce the amount of blood flow and to help kind of like, tamp it off essentially.
Right.
And that's going to be less effective in older and younger people. There might be some medications patients are on, like, beta blocker kind of things that can affect some of that. So, be aware of those things as well. That patients might not clot as well as they should for a variety of reasons, essentially.
And kind of inversing what the topic is today is, there's other reasons for people to clot, and clots can cause a whole slew of problems. If you're interested in us doing a video on clots, we can definitely do something along those lines. But like, big factors that cause people to clot naturally, right? There's obviously the intrinsic factors, like you're saying, like factor 9 and like platelet numbers and things like that. But from the inverse relationship of that, people are going to clot more when they live stagnant lifestyles. So typically are older folks, they sit in their chairs all day, they watch their TV, maybe they're smoking cigarettes on their oxygen cannula. That all causes that blood.
Never.
Yeah, no, not one time. But that causes that blood to stop. And a lot of people don't understand that even when we walk, just walking around, that you're forcing blood to move by having muscle contraction, you're getting that blood to continue to circulate. And that's a big portion of it. So if you're interested and you want us to do something on clots, let us know. We'd happily do that.
Off topic, did you ever have anybody light their face on fire? One of those smoking with a cannula people?
No, I've seen it a couple times, and I'm going to put that out. I've heard some horror stories, though, about people walking into charred houses, and a lot of beef jerky references, which is very calloused EMS, just generally.
Yeah, for sure. I never had one. I've heard plenty of people singeing their facial hair off and stuff because, oxygen by itself is not just enough, right? You need to have, there's also the fire triangle, which is heat, oxygen, and fuel, I believe it's been a while since I did my fire academy.
Which oxygen can double in as a fuel a little bit too, because it's non-flammable, but it's an accelerant.
Yeah, it's not a fuel on its own, but higher levels of oxygen cause fires to burn faster, right? Like, if you've never heard about what happened with the casinos back, it was like the 80s. There were, I don't remember what casino it was. I think it was in the 80s. There was a bad fire, and casinos used to have higher levels of oxygen. They would pump in higher levels of oxygen into where everyone would gamble, because higher oxygen, you feel more alert. People would stay up later and longer gambling. And so they were pumping this in, higher level of oxygen within the casino, and there was a fire, and it ripped through it way faster than it would have otherwise, because it's such a hyperoxygenated atmosphere.
I mean, that makes sense. Same thing with like airplanes. That pressurized cabin. There's a reason you don't smoke on airplanes. Yeah.
Also, because gross.
Yeah. Also, just nasty generally.
Yeah. But. So A&P, it's pretty straightforward. It's pretty basic what we need to be thinking about for that. So coming down to bleeding, there's two major types of bleeding that we need to be aware of, right? There's going to be kind of the easier one to recognize of external bleeding, and there's going to be the internal bleeding, right? So maybe jump into external bleeding a little bit first.
Yeah, for sure.
Most people probably know, if we're talking about external bleeding, typically we're going to have a couple different types we could see. We could have like arterial bleeds, venous bleeds, and then like capillary bleeds, right? How are you going to differentiate those three?
Right. I usually describe, easiest one, let's just get out of the way, is arterial bleeding. Some obvious indicators, if you have arterial external bleeding, the color, it's going to be a bright red. It's not like the darker red blood that if you think about a cut that you've had and it's kind of got that, I don't know, kind of more maroony look to it. But it's going to be bright red, but then on top of that, it's going to be spurting, because remember, arteries are going away from the heart. They're the ones that are attached to that left ventricle there. So when you see someone with an arterial bleed, you're going to see that spurt. So every time that heart beats, you're going to have just more and more blood being shot out at a high rate. Versus venous bleeding, that's kind of more of like your traditional, if you've like fallen down and cut your knee or whatever, you have that blood that just kind of pools and then slowly starts to run, for lack of a better term. And then lastly, capillary bleeding. I think of that like paper cuts. If you cut your finger and then you just have that slow ooze, you cut deep enough where you see the white of your skin, that dermal layer, and then you just watch it slowly fill. That's capillary bleeding.
Yeah. So like you're saying, most of the time we're going to see venous and capillary bleeding, but arterial bleeds obviously are a 911 specific thing that we're going to see, or it shouldn't necessarily 911, like an emergent medical issue that we might go on.
Right.
So really important for us to be able to recognize, and it's not always as easy as maybe you would think. And I've definitely seen both sides of like spurting and hitting the ceiling, and not quite that bad, especially later on with the arterial bleeds. That squirting that we're looking for might not be as pronounced because their pressures are lower. Right. And so that's almost, not almost, it definitely is worse if we get to that point. We really need to be kind of keen on catching that early and being able to address that early.
Right. And there are some conditions that can, like the spurting can kind of have like a mimic to it of sorts, like varicose veins. Have you ever had a gnarly varicose vein patient?
Oh yeah, it looked like literally I walked into a room and it looked like a horror movie. Like there was so much blood on
Just
everything.
Jackson Pollocking the walls.
Yeah.
Yeah, I had one, and it was in a shelter, and it was a gal who nicked her varicose vein shaving her legs, and it was just bleeding and bleeding, and it was shooting and hitting the shower wall, but the color was the big indicator, because it's like, that's a lot of blood. And then kind of putting two and two together, it's like, oh, okay, maybe we have a little more time than I thought initially. Still something that needs to be taken care of, obviously, but it's the life threat radar kind of goes down a little bit more.
Yeah, the one that I saw that was like that, like you would have thought the person was very dead, just looking at the room, but she was grossly stable. It was actually an overdose patient. We don't know where the blood came from, but we know she had like varicose veins, and we could find where it had been bleeding. We weren't sure the story, I should say. We knew where the bleeding was from. We didn't know the story because she had overdosed. The only EJ I ever got in the field, actually.
I never got the chance to do one.
Yeah, it's really scary to poke a needle in someone's neck. But I was in medic school, and we couldn't find a vein. My preceptor's like, look at that juicy EJ. I was like, oh, I guess we got to.
I looked at one time on a gal. She was a known IV drug user, so just scarred up, nothing. I think I poked her like 4 times looking for stuff. And then I was like, well, look at her EJ, and she had just a frog neck. It's like, there's no seeing that. I looked.
Hey,
thankfully, we got there in time.
Be nice to us with no necks.
Hey, I'm not calling anybody out.
So when we're talking about bleeding, there's different types. It's also important for us to think about kind of the time of bleeding, because that's really important when we're talking about maintaining that homeostasis and that perfusion, right? It's important for us to remember that not only is the amount of bleeding necessarily important, but the speed of that bleeding is also really important, because our body can compensate, but it needs time to do so.
Right. And we kind of talked about it with the pumps, pipes, fluids, right? Our heart, we can adjust the rate. Our pipes, the vessels, we can adjust the diameter on those. Blood is you're kind of stuck with what you got a little bit, and the average person has anywhere from 6 to 7 liters in their body. So the time frame is going to be huge, right? Because if you've got, 6 liters of blood in your body and you've got a slow bleeder over the course of 4 hours that's never been stopped, that you can lose the same amount as you would from an arterial bleed quickly.
Yeah. Yeah, it's important to remember the body can usually lose about 20% of blood volume without major repercussions, but beyond that, we start to really suffer. And it's also really important for us to remember, like I was saying, time. The example I always use is blood donations, right? Because they take out a good amount of blood, but that's over 15 or 20 minutes. They're slowly taking that blood, and your body's able to begin to produce more cells and everything to replace what's being lost, and your veins, your arteries can clamp down a little bit to reduce the size of the container, and you're going to be able to manage that okay. Versus, somebody nicks their femoral artery and they lose that same amount of blood in 30 seconds. The body can't catch up to that.
Right. Too harsh of a gradient there.
Yeah, it's just way too fast, right? So really important to remember that. And it's really important to remember that perfusion triangle, and what we are going to see as responders for patients that have lost that blood in a short amount of time, right? So we need to think about that fluid. As the fluid levels go down, the body wants to keep the pressure the same. How's it going to do that? The easy way typically that we're going to recognize is heart rates.
Right.
So if you have a patient with some sort of bleeding, it's important for us to really be paying attention to that heart rate. And if you see a heart rate of 105, that should be a big sign for you, right? Like especially when you're new, you fall into the trap of like, if it's close to normal, it's probably all good, but we need to be thinking ahead of the game. And so a slightly tachycardic heart rate in a patient that's bleeding without any other obvious reasons for it, should be a pretty alarming for you. That's compensated shock.
Right. And then, we harp on it all the time when it comes to like your assessments, especially for like NREMT checkoff stuff. But feeling the pulse, thready pulses. If you feel a fast pulse, that's kind of hard to feel, which, caveat, there are some people who just have hard pulses to feel, just anatomy wise. But it's so important to make sure you're actually palping a real pulse, especially, I'm sure you have similar experience, but the longer you do this job, you can actually start to have a pretty good ballpark on people's pressures just based on what their pulse feels like.
For sure.
You know, and so if you feel that pulse, it's like, it's a little weak. And even if you don't see external bleeding, time to start shifting gears to maybe internal bleeding or some sort of, clot issue or whatever. But keep that in mind. That's a really important asset for you. And it's something you can get really, really quickly. Give you a lot of answers.
Yeah, like we tend to teach the handshake introduction kind of a thing where you just kind of shake the hand, say, hey, I'm Chris, I'm a paramedic, and like you reach down as you're shaking the hand to feel that radial pulse.
Right.
Because rule of thumb, if you can feel a radial pulse, the systolic is 80 to 90 or above typically. If you can feel a brachial, it's like 60 or 70. And then carotid's usually like 40 to 50 if you can feel a carotid.
Yeah, somewhere I always thought carotid was around 60, but yeah, same general thing.
And I don't think this is definitely not an exact science. This is down and dirty EMS medicine of like, I have short amount of time. How can I find really good information really quickly, right? If they have a peripheral pulse, they probably have enough pressure within the system to maintain perfusion to the brain, essentially is what we're thinking about here. And if you don't, then we need to be concerned and start acting that way.
And then on top of like, kind of piggybacking onto that handshake, you're feeling their skin, you're feeling condition, you're feeling the temperature, like cold hands, like, a lot of women that I know tend to have just typical cold hands, and it's usually a circulation issue, and so you can, especially if it's, I'm making this up, but like a mid-20s pretty fit dude, and you feel their hands like, oh, you're cold. Like, what were you doing that? And I'm feeling a thready pulse. That's immediately, I've got so much information in less than 10 seconds.
Yeah. Yeah, and then and skin and color too is really something for you that you can easily, as you get close there, to shake the hand, look in their face as you get up close, and you can look for that, because our body, like we were saying, if we lose a lot of blood, the easy thing the body is going to do is clamp down veins and arteries, and it's going to do that peripherally, and so we're going to get that pale skin, right? So, you can find some information really quick,
right.
And if you're going on a patient and you see blood on the ground and these things together, that's big indication of some major bleeding.
Right. I tell my students a lot, blood does a couple of favors to our skin. Gives us color and gives us temperature. And those two indicators are things that, we can talk about, but until you actually feel it and see it, that's when it's like, oh, okay, you put two and two together very quickly. You had mentioned seeing blood on the ground, and I think a disservice that it's hard to do with a class, outside of just making messes, is depending on the surface, blood looks different.
Oh yeah.
A linoleum floor, like if you were to take an 8-ounce glass of water and pour it on a linoleum floor, it's going to look like a lot of water, right? Same thing with blood. A good example would be childbirth, because women lose a pretty decent amount of blood during that typically. And I believe it was like 12 fluid ounces or so. You dump out 12 fluid ounces onto the floor, it's going to look like a lot of blood. That's a fairly manageable amount, actually, and so just things to consider, right? Like if it's on carpet, it might be pooled in one little spot, but if we're on hardwood floor or any harder surface, it's going to look like a lot. And so don't necessarily gauge it as like, oh, that's a ton of blood, we got to get moving, right? Obviously, circumstances are circumstances. If it's something you got to get moving. But if you can double check that and then kind of put the pieces together by talking to your patient, getting the circulation clues that are already there for you, it's going to go a long way.
Yeah. If you have the ability, you're in class or something, just take a 10 cc syringe of saline if you can, and just pour it on a desk. I mean, it's so much more than you would think, and so it can make judging blood loss very difficult for us. So a lot of the time, what they'll want to know is more like, I used this type of bandage, this whatever, and I soaked through these many, is typically a better indication of blood loss than like, well, it looked like this much, right? Because I mean, that's just so subjective realistically, and we're just not good at it. We don't have, there's not really a good way to train on it, because just like you said, different surfaces, maybe they're outside and they're on dirt, and how much soaked into the dirt, right? Like how there's so much that can go into that, it can make it really difficult.
Right. And depending on the call too, like when people bleed, they tend to get disoriented, especially, if people are not good with blood, they start to panic a little bit. I had a call for an older gal. She fell down, bumped her head. She had a little head bleed, and scalp and face bleeds. They bleed a lot because we have a lot of vasculature in our face. And I walked in, it was kind of like you were saying with that varicose vein. This gal, there was blood everywhere. There was handprints. It felt like a horror movie, like dragged across walls because she'd fallen and then picked herself up and then touching everything. And it was one of those where it's like, she's bleeding. All her blood is on the ground. I can see it. I don't know how she's looking at me, right? But it was actually a fairly controllable bleed. So there's things to factor in there. Read your patient, not just the scene. The scene gives you clues. Your patient gives you answers.
Yeah, that's a good point to add on top of it too. Is head wounds and face wounds bleed like crazy, like way worse than you would think, because it's so vascular. Which is why face is so sensitive, right? Because there's a lot going on the face, and so there's a lot of small vasculature to the face that just bleeds like crazy.
Yeah, I had a teammate in college. We were in our locker room, and he stood up, and our lockers were above our seats, and they had like the little clasp for like a padlock to go on. And he stood into the down piece of it, and he bled and bled and bled. You would have thought that someone was cutting his fingers off with how much blood was on our floor, and we had a red floor, so it was notable. Of like, oh, that's a lot, but it was just a 1-inch lack on the top of his head, and just they bleed, and you got to be ready for it.
Yeah. Story that just came to me, not my story, but I had a partner who talking about like estimating blood loss, who went on a call for somebody that slit their wrists, but they were in the bathtub. And so they had to transport him, and they got to the hospital, and they're like, how much blood do you think they lost? And they're like, we don't know. He was in the bathtub. It was draining out of the bathtub. And it was like a big discussion between the hospital and the EMS crew, as they were very upset that they didn't have an estimation of blood loss. And they're like, what do you not understand?
Yeah, it's draining.
How are we supposed to, should we just make up a number? We can just make up a number.
Yeah. Do you want me to say a bathtub full?
So external bleeding it's pretty simple because it's visual, right? Whether or not we're going to be able to judge how much blood was lost, we can still generally see external bleeding. The hardest parts are going to be hairy areas. So that's where you'll see a lot of people will do the gloved hand pat down of the head, because head wounds tend to bleed a lot, but it might not look like it because it's just saturating the hair. So that's something you might see people do that good all over, hands all over, kind of run your fingers through their hair and then pull up your gloves and look and see if you have blood, which is one of the reasons why, as cool as black gloves are, most people don't use them in EMS because it hides blood really well. So that's why we a lot of the time you'll see like lighter colors, because it's easier to see that blood on your hands.
Yeah, and I was trying to do, for most trauma assessments, start with that rapid blood sweep. Just run your hands down. Like, obviously, if it's a conscious person, they're going to tell you where they're bleeding, or they can kind of guide you. But if you show up and there's an unconscious person and you know blood, just run your hands down. If there's blood on your hands, we got a hole, we got to plug that, right? So it's quick indicators, things. This is just trauma, right? Trauma essentially is plug the holes, dry fast, get them to a doctor.
Yeah, trauma's cool to look at, but way more simple for sure.
And then bleeding, we talked about surfaces, that can be, I would categorize that as a distracting injury, right? Like if you see tons and tons of blood on the floor and they've just got a head wound, you're going to be focusing on the blood, and you're going to be panicking about some stuff. And, once again, read your patient. Yeah.
Yeah, I've definitely seen that as an FTO with new EMTs of, freaking out about like, we need to be going, whatever, and there's the patient sitting up comfortably talking to us with a good head wound that's bled all over the place, but they get distracted, like you said, they get caught up in that, and they're missing the big picture, because it is very visual, and it's scary when you're new to this and you see like Hollywood levels of bleeding. You're like, oh, this person's dying, but not necessarily the case.
Right, right. Back to spurting, your Hollywood reminded me, if you've ever seen like Kill Bill, that's not the same amount of bleeding. Like you cut someone's arm off, it's not going to be like, like a spray can going off. Just keep that in mind too.
Surprisingly, amputations don't tend to bleed as much as you would think, because when we have that clean cut on the veins and arteries, they tend to like kind of snap closed, right? They're kind of elastic, almost like rubber bands a little bit. And so, it's a lot less than you would think a lot of the time from amputations.
Which I always thought that was like counter or counterintuitive. That's what I'm thinking of like, if someone cuts their hand off and they have vascular constriction, typically we vascular constrict to raise pressures, so it was always one of those in my head. It's like, so we're killing ourselves by crimping down, but in reality, you're right, it's like a rubber band that cinches down on that area, depending, situational, patient dependent.
One thing that and I teach this more for teaching IVs for like advanced students, but one of our sympathetic responses that we're going to see to pain or trauma is going to be we're going to have a sympathetic response to pain or trauma, and so that sympathetic response tends to cause vasoconstriction. So you might see a little bit of that, and that's part of it too. It's just naturally we're gonna have that sympathetic response to clamp down, which is to help us stop bleeding, right? So,
right. You want to talk about external treatments?
Yeah, we can do treatments, and then we can move to internal after for sure.
So remember, direct pressure is going to be your go-to first every single time. Now, if it's an arterial bleed and you show up and it's massive, bright red, spurting, pressure is not going to cut it. It won't. We're going to have to move to a tourniquet at that point. But for the most part, direct pressure stops bleeding incredibly well.
Yeah, I have stopped a femoral bleed with we use something called an Israeli bandage, which is a pressure bandage that is actually, I don't know, not my story, so it's kind of funny. But there were we went on a call and there were a couple people that were practicing their self-defense moves, is what they told us, with a pocket knife.
Oh, sick.
And they accidentally stabbed the girl in the leg with a pocket knife, and it was, like, I don't know, 3-4 inch blade, not a big pocket knife, but stabbed her, and it was for sure a femoral bleed. And we got there, and fire was like working to put the pressure bandage on, and you could tell how much, like, there was significant blood, but pressure bandage worked great. She wasn't bleeding or anything, and we took it in as a priority 1 trauma because it was, penetrating trauma above the knee, which for our system is a level 1 trauma, the highest trauma. We took it into the trauma center, and they kind of laughed at us, like, "Oh, arterial bleed from a 3-inch pocket knife, sure." And I was like, "Look, we
Just a
saw
messenger, man.
We saw it. I'm telling you, I seen it." And so it was funny watching as they're like, "Oh, whatever," like, kind of scoff at us, and they start to undo the bandage, and she moves her leg, and just like big old fountain spurt from the femoral where she punctured the femoral, and like a big spurt after they took it off, and she had moved and kind of broken the clot. I'm like, "Ha, told you."
Yeah, that intrusive thought to be like, "You're wrong. You're wrong."
You maybe make 10 times as much as I do, but I was right.
Yeah. Not to brag or anything, but I'm bragging right now. For sure. So if arterial bleed, we talked about it a little bit, but tourniquet, right? So there's a lot of back and forth about tourniquet application as far as like techniques go. A lot of us have been trained high and tight. The higher on the extremity, tighter you can get it. That way you're crimping off the circulation at the base. I've seen 2 to 3 inches above the injury. Kind of just depends on the literature you're going off of.
Yeah.
As far as, and also another one this is one that I have a gripe with it, is in the textbook. It's like, so if one tourniquet's not cutting it and they're still bleeding, and that is as tight down as it'll go, the next one says apply a second tourniquet adjacent to the first one. Well, what does adjacent mean? Is that above or is that below?
It should be above.
Right.
Because we don't want like compartment syndrome and all that. We don't want to go below. We already have pinch that area, stop that area, so we don't want to go below that and cause issues. It should be above.
Right. So I did actually talk to a couple TACMed people about this, and it was like, I told them my gripe with the textbook, and in a perfect world, if you're going high and tight, you're going as high up as you can. You can't get one much higher, right? So one of the TACMed folks I was talking to said, well, what we're trained is to go about a finger's width below the first one if we have to. And the reason being for the finger's width is it's such a small space that compartment syndrome is very unlikely to settle into that spot. So whatever your protocols say, whatever, your textbook's always going to be your go-to. But if you can, second one goes above every single time.
Yeah, I think 3 inches is kind of a baseline. The high and tight, I think, is more of a tactical military application. In large part, I think that is just because if I have a tourniquet here, I kind of have lost the use of my arm, right? Where if I have it high and tight, I think the purpose is if they get shot, they can still hopefully manage their rifle or whatever. Yeah. I know that's what we're taught by Justin, who's on TACMed, and having discussions with him. That's kind of why they teach that, to hopefully not totally eliminate that limb from usage as needed, where that might happen with, doing it just above.
Right.
The real big thing, though, is we can't do it on the lower portions of the extremities. So if you think about your forearm here, we have 2 bones. Humerus is 1 single bone. The lower arm is the radius and ulna. We have 2 bones. There's going to be vasculature that runs in between those 2 bones. If we try to put a tourniquet around that, we're not putting any pressure on that vasculature between the bones, right? So there's not squeezing anything off, whereas the humerus is just the humerus, and so it will fully engulf and squeeze around the humerus.
And the same principle applies to the leg, right? Your tib fib and your femur. It's the same idea there. And then always, just because we've got to double check cross our T's and I's and such. I just blanked what I was going to say. Oh, make sure you don't put it on a joint. Sheesh. We don't ever want it on a joint, similar reasons, right? And then on top of it, you're impeding potential limb usage. Yeah,
you can cause some issues with that. So tourniquet's pretty simple. This is one of those things that you should be really practice at to be really quick with it. I always teach for tourniquet usage. I've seen people that will undo with like a cat style tourniquet, undo it and like pull it fully straight and pull it out of the little buckle. Sorry, I just kind of hit the mic. That's not a good idea. I really teach to stay away from that, because once your hands are blood soaked and all of that, it's really hard to thread that back through. If you can't undo it to its full length without taking it out of the little buckle there and slide it over the extremity, it's not going to fit anyways.
Right.
So don't take it out. Just pull it, make it as big as you need it to be, and then cinch it down over top of it once you're putting it on.
And then a lot of systems will, once you put a tourniquet on, we're not taking it off. That's above your pay grade to make that choice. And then I was actually talking to our CPR director about this, because they were talking about tourniquets and what she was taught back in the day. And basically a tourniquet to them was a death sentence to a limb. That's not so much the case. New science has come out. It takes about, I think the longest applied one was about 4 or 5 hours without loss of a limb. So just because you put a tourniquet on someone does not necessarily mean, oh, that arm's doomed or that leg is doomed. They still have time. That still is, you're still falling into your rapid transport shock treatment. Let's get them to a hospital.
Yeah, I was reading a study about this a while ago. I'm trying to remember exactly what it stated. I think that there's been up to like 20 hours recorded with no long-term issues with the tourniquet, but I want to say it's like 4 hours or so is the common time where there starts to be issues. But realistically, our transports are going to be, under 30 minutes most places, and so, and even still, like, are we worried about loss of life, or are we worried more about loss of limb? So yeah, when I went through EMT school, which was 15 plus years ago, right? Like that was the mentality. Like, it's a death sentence. We learned direct pressure. We learned pressure points. So we would actually do pressure points back then and elevation. And then we learned tourniquets is like, this is to save the life kind of a thing. And especially the military just is the one that does lots of good studies on this. It's just found not to be really the case. So I wouldn't say be super aggressive about tourniquet application, but don't hesitate thinking like, oh no, I've heard that the arm's just going to fall off before we get to the hospital.
Right.
Like, if you need to stop an arterial bleed, just put the tourniquet on. I've only ever put one tourniquet on in the field, and it was for a finger laceration. I know, right? Kind of weird. The lady was doing the dishes and stumbled and fell with her hand into all the knives in the little silverware area. And it was one of those ones where, like, I felt so silly putting on a tourniquet, but she was sitting on her bed when we got there, and she's already a little bit pale and holding a towel, like a bath towel that's dripping. It was so saturated, it was dripping. And like, we're trying to like pressure it and nothing is working. And she's like, we could just see her skin tone, and we all kind of looked at each other like, we're going to have to put a tourniquet on this, huh? And it worked great. And it was another one where we walked into the hospital and they're like, you guys put a tourniquet on for a hand? And I was like, look. And then like they like come over to the patient, the trauma surgeon or whatever, and he sees the towel and feels it, and he's like, oh, okay, I get it. Like, I get why you did it. So I don't know what she sliced open, but it was significant. It was crazy.
I only ever put one on, and it was for a wrist cut. And yeah, it was pretty non-eventful. Put it on, show up. It was Father's Day, ironically, and the guy around his kid decided that was the right time to do that. Yeah, it was. There was a lot of messy things on that call, but I mean, really straightforward. Worked like a charm. And most of the time, though, when I've dealt with tourniquets, it's because PD has put them on prior to my arrival. Which, blessings to PD. Not all of them were necessary, but I've also, not for me, but I've heard of them saving people's limbs.
Oh yeah, for sure.
For sure, just being quick on the draw, and that's what they're trying to do. And we're trying not to take it off, and we're going to trust their judgment a little bit.
Yeah.
It also gives you someone else to like, if the doctor's like, seriously, you're like, listen, dog. You know?
Look, it's not me.
Yeah.
I promise.
Point fingers.
Yeah, so outside of that, right, we've got our direct pressure.
Mm-hmm.
We have tourniquets.
Mm-hmm.
We're not going to really get into it here because it's still a fairly new thing protocol-wise, but wound packing is also something we can do.
Mm-hmm.
And wound packing specifically is going to be for the junctional areas that we can't
Mm-hmm.
place a tourniquet on, right? So if somebody's shot up in the armpit, we're not able to put a tourniquet on it, but we
Right.
might need to do more than direct pressure. And that's where wound packing is going to be, right? Like up in the armpit shoulders or kind of in the hips, the junctional areas.
Have you ever dealt with a junctional tourniquet at all?
In practice here, we have one. And for the PHTLS, you pull out the junctional tourniquet. So it's a slick little piece of equipment. It's pretty easy to apply.
I don't think I've ever actually played with one too much. I'm going to have to get into that.
Yeah.
I mean, there's so many different techniques too. Just like I was telling you about, there's a technique to stop, bleeding in the neck, and it's creative, right? A lot of EMS is creative splinting, creative bandaging. So do what you got to do to get that pressure on there,
Yeah. And that was where I was going next. There's a lot of times where, you can't put a tourniquet or something on the head, right? You're just going to have to be creative. So there are some methods for like head wounds or like you were talking about for like armpits or something like that. So you can do some research, but it just comes down to like with a lot of things, having like good basic understandings of the principles of what we're doing and being able to apply those in different situations.
Right. And it shouldn't need to be said, but I'm just going to say it. We don't put tourniquets on people's necks or blood pressure cuffs on people's necks. Let's just think about what happens if we do that. You'd be surprised how many times I have to be, what happens next if that happens, So just keep that in mind. We don't tourniquet above the shoulders.
Yeah, not a good idea.
No.
That's a big old no.
Yeah.
Another thing we don't talk a lot about that can be helpful for external bleeding treatment is going to be splinting, especially if you have like a good like pressure splint or air splint. Those can really help to create essentially a pressure bandage.
Right.
So that's another thing to think about maybe for especially like your multi-system trauma patients. It's a little kind of an easy thing to throw a splint on, and that can possibly help with that external bleeding as well.
Right. Yeah, do yourself a favor. You're splinting the injury and hopefully stopping the bleeding if it's a big open wound.
Yeah,
for sure.
It could be kind of double duty there. So internal bleeding. Internal bleeding can come from a lot of different things. The easy one to think about is going to be our solid organs, right? Solid organs are going to have a lot of vasculature because usually they are doing something blood related or perfusion related, right? Or something within the blood is filtering, something like that. And so there's a lot of blood going, liver, spleen, all those solid organs. So the lacerations of those can be pretty profound bleeding. We can have bleeding from broken bones. That's another thing that, bilateral femur fractures can be life-threatening bleeding. Pelvic fractures can be life-threatening bleeding. So important for us to recognize those and be aware of those as well.
Right. Knowing your anatomy for sure with like the quadrants of the abdomen is huge. One thing that, the textbook never really touches on, it mentions it and then kind of glazes past it, is that hepatic portal vein. One of the largest veins in our body comes from our liver. So if there's true liver separation from the vasculature, they are going to bleed internally a lot. And it's going to be, there's nothing you can do about it. You just got to recognize and drive fast. But you were talking about femurs and pelvis, right? So our femur, the kind of rule of thumb is you can lose 1 liter of blood per femur fracture, and then you can lose up to 2 liters in the pelvis. So, if you think about what it takes to fracture a femur, that mechanism is probably great enough to impact the pelvis as well, if not the other femur. So you could lose upwards of 4 liters of blood into your body, into the celli, as I was told once.
Yeah, and that's half of an average person's blood volume. It's going to be, as a student said recently, as I was saying, like, 6 liters or whatever is typical blood volume. He's like, like 2 liters of soda. You're not wrong if that's how you remember it.
Yeah, your math is different than my math, but for sure.
So, if you have a massive trauma with bilateral femurs and a pelvis, you could be losing 2 liters of soda, right? You could be losing 4 liters of blood into your soft tissues and all of that.
Yeah.
So that can be pretty significant.
Oh, yeah. And then, like I was saying, recognition's huge. And especially when it comes to the abdomen, we don't have, some places might have mobile ultrasound, but we are not one of those systems here locally. recognizing the early signs, things like distension, abdominal guarding are going to be huge. Do not rely necessarily on bruising or blood pooling, because that's going to take time to show up. And if you show up and they've got a massive bruise on their abdomen with distension, you are very late to that game.
Yeah. So feeling the abdomen, look for a hot belly. So when we say hot belly, it's really warm to the touch as the abdomen starts to fill with blood. That's important. And this could be a time where we may want to look for rectal bleeding too, because maybe as it fills, you might get some bleeding out of the rectum as well. So something that maybe not the most fun to think about or check, but it's something you might have to be looking for as well.
It's going to find an outlet one way or the other.
Yeah, exactly. It's a finite amount of space, right? It's going to go somewhere eventually.
Right.
So we need to be aware of that.
Yeah. And not all internal bleeding is necessarily traumatic, right? Like if you talk about GI bleeds, those are huge when it comes to that. I've had the pleasure or displeasure, whatever you want to call it, of seeing both avenues of an upper GI and a lower GI. The upper GI, the gal blamed it on the chow mein she ate the night before, which I don't know. But it looked like someone had basically poured strawberries that had been soaked in sugar just everywhere all over her floor with chunks in it because she'd been vomiting. The other guy, the lower GI, was still one of the most horrific things I've seen to this day. It was, I don't know how to describe it, in like a purple color, which was kind of a weird thing. But I walked into this bathroom and it was like the kind of bathroom where it had like the separate toilet room. And this guy's in that toilet room and Fire's just kind of looking at us, looking at him, right? And there was blood just all over on the walls. And I was like, okay, and I was working the ever elusive triple medic that day. And both of my partners were like, we got to go move the ambulance. It's like, both of you? That's weird. So I was talking to the patient and I was like, yeah, anything, pain, anything you think could have caused this? And he's like, well, looking at it, I did eat some blueberry jam this morning. And it's like, you think your jam did this? Like, you've got problems, man. And yeah, it was a lot. And he was pale, I think a systolic of like 75 or 80, very, very low drops, and so just keep that in mind. It's not all traumatic induced, but it's still bleeding we got to contend with.
Yeah. And so what you're talking about is going to be melena. And so melena is essentially digested blood that is going to be coming out. Or hemaemesis is when we're vomiting blood. So you might hear both of those terms.
Or coffee ground emesis is another one.
Yeah. Coffee ground is going to be it's going to be digested blood. So it's going to smell real bad. And then it's going to be that chunky, darker color. So essentially, the lighter the color is, the less processed it's been, right?
Yeah.
So if you have a patient with
like a bleeding ulcer.
Yeah, like a hemorrhoid or something. Maybe they're complaining about some blood in the toilet and it's bright red. Maybe they just have a hemorrhoid, and so you're going to see it there. Which that's not super concerning. It's going to be when it's that dark color because it's coming from somewhere within the GI tract that needs to be tracked down and fixed.
Right. I mean, I'm sure you've been dispatched to it just like I have, of like rectal bleeding, and you show up and they're like, yeah, there's blood in the water. And you're like, you have hemorrhoids? Well, yeah, what does it have to do with anything? Here we are, right?
There's the blood in the water.
Yeah, that's where that melena is really, really important, that dark, tarry. It's not always it was not as black as I was picturing in my head over time. And then, yeah, it's like kind of a purpley color.
Another type of internal bleeding that doesn't really fit into what we're talking about, but is still obviously very important, is going to be head bleeding. Internal, like within the brain or something like that, right? If we have a head bleed. So that's its whole own separate list of signs and symptoms and ways to recognize that.
Check out our head injury podcast.
There you go. Yeah. And it can be spontaneous, right?
Yeah.
It can be spontaneous.
I had a patient with that. He had
a ruptured aneurysm.
Bilateral. So it was an aggressive or combative guy in a nursing home. We showed up. He was a Marine, older retired Marine, and he was just fighting. And it took, I think I gave him 2 doses of Versed just to get him to chill out, and so we cuff him to the cot. And then when we took him back in, I ended up staying in the hospital for like half an hour just to wait for cuffs. And then when we came back, I was like, hey, what's going on with that guy? Is he still fighting? They're like, no, he's super nice. He's super chill. He ended up having bilateral spontaneous head bleeds with a 14-centimeter diameter bleed on either side.
Ooh.
Yeah, he was after it for sure.
Maybe he didn't shift at least because it was both sides just pushing towards the center.
Yeah, that pressure was building.
There's no midline shift.
He got taller, which was weird.
Sir, you look like a cone head. Is that normal? So yeah, internal bleeding, a lot of that is going to be based off the MOI. We need to be thinking about that if we're assessing for internal bleeding, right? Like Is there a bent steering wheel? Was the seatbelt worn incorrectly if it's a car accident, right? Like we need to be asking those kind of questions. And then, like you said, look for the simple signs first. Feel for that rigidity, maybe some guarding. So guarding is where, it hurts to touch, so they'll kind of like flex their their abdomen muscles and kind of like try to stop you from pushing on them. So pay attention for that guarding.
I've heard a couple definitions of that. So like when you go to, and they tense, and I've also heard if they're holding their arms over the space and they don't want you to touch it, some doctors have categorized that as guarding as well. So kind of keep that in mind. There's a couple of definitions.
Yeah, I think they're kind of, two of the same thing essentially. If it's just like it hurts, and so you're whatever way you're stopping people from touching it, right? Like, or putting pressure by either flexing or physically doing it with your hands. So look for that kind of thing, for that internal bleeding, and really a lot of this and so much of it especially the EMT level is just recognize and go fast to the hospital, right? Because this is the people that drive Ferraris that fix these things, not us. Can't tourniquet a liver laceration.
No, I've tried. I haven't. Just saying. Another type of bleeding that we kind of haven't touched on, but we touched on rectal bleeding, but like vaginal bleeding is another one. Internal bleeding. There's a slew of issues that could be coming from that, from anything from, placenta previa to abruptio placenta, or even just trauma. But that's still something also, we're never going to be able to control. You talked about wound packing, and I want to talk about it right now as well. If someone has an open abdominal wound packing is never, ever, ever, ever your option.
No, that's why it's just the junctional areas.
Because you're just going to be in, like, same with the chest. Anything that's a cavity, you're just filling that cavity full of something that should not be there.
You're going to keep stuffing stuff in there until they die, essentially, if you're in like a cavity. So, kind of on the same, just looking through our notes here, stuff we didn't really talk about. So wound packing, and there's also hemostatic dressings. I've never worked anywhere that carries them. I think they're fairly expensive for the amount of, EMS is a business, so there's definitely a little bit of like, this would work really well, but we don't have the capacity to either purchase it or keep it on the ambulance or engines because it would be recycled too quickly. But hemostatic dressings you might see out there, and so those are going to have some sort of chemical or something that will help to stop the bleeding. One thing I've been told about those from people that have worked with them, or we had a guy that used to teach with us that taught TCCC, and he's a military guy. He really cautioned, especially they would sometimes carry just kind of powder.
Yeah, the quick clot stuff.
Yeah, like really be aware of your surroundings, because he'd seen people get it in their eyes. And that's just like, I think it's kind of like, maybe not gunpowder, but something similar that just like cauterizes real fast. And so he'd seen people get like eye injuries because they went to pour it on a wound, and the wind kicked up and it blew it in their eyes.
Wow, so that's a nightmare.
Yeah, keep that in mind if you're using quick clot, anything like that. Really be aware of your safety and the environment when that's all going on. Hemostatic dressings I think are typically going to just kind of be pressure dressings that have some sort of chemical that will help to stop
your department will know if you have it or not, and it's worth, if you're not sure and you're applying to a department, maybe asking the question just to see what you've got to work with.
And you should be trained when you get out there,
for sure.
We didn't talk about pelvic binders for pelvic bleeding, right? But that, and then same thing with like a traction splint. So if you have, femur fractures, possible pelvic fracture, those kind of things, traction splints can help with that. Pelvic binders, especially if you can kind of like get a good visualization of like an open book pelvic fracture, and then you think what the binder does, help to kind of close that off. That can really help to stem that bleeding. So those are really important. Pelvic binding I never heard about until a couple of years into my medic career. Like we had never talked about it in class. I never heard about them before. But there's a lot of now there's a number of different commercial products out there. So something to think about if you have that situation.
I feel like the commercial products are a little bit newer because like initially we were trained with sheets and towels
sheets,
and like if you've got them, use them because they're there for a reason.
And then one thing we didn't talk about, I think kind of the last thing we have on the notes here is going to be bleeding from the nose, because that's obviously something that we see. And I've gone emergent for a nosebleed before with an elderly person on blood thinners that had waited a long time to call. But it can be pretty significant bleeding from the nose. So something to think about, especially those blood thinners patients, because they, I get bloody noses all the time. My son gets bloody noses all the time. Just genetically, we're predisposed to it for whatever reason. Thin
Weak
membranes
mucous
or something.
membranes.
Yeah. Thanks, Mom. But to me, it's not a big deal. Like, oh, my nose is bleeding. Take a little tissue, stuff it up there to do a little pressure on there, and then 20 minutes later, pull it down, and I'm all good.
No.
But it's a different story with some of these patients on blood thinners, and I mean, it is a 911 emergent call. Sometimes where they need to go and get cauterized to the hospital. I don't know if they still do, but hospitals used to have cocaine because it's such a potent vasodilator or vasoconstrictor that they would do. And I think it was not actually like street cocaine. I don't think it would get you high, or I don't know. But
It's
I know that
pure
used to
stuff.
be a thing that they would put up in people's noses to help that that profound vasoconstriction.
That's gonna be a heck of a bill. Heck of a bill.
Yeah, you're just gonna have like a cartel member walk in, like.
Yeah,
It'd be
I can't even pretend to know how much it would cost. It'd just be a lot.
Especially if it's pharmaceutical, whatever, like, hospital grade, it's going to be, I'm sure it'll be very expensive.
True. One of the gnarliest bleeds I ever saw, and it was ironic because it was like right after we got TXA rolled out, and they had talked about it, like this could happen. And I was like, that doesn't sound likely, but it did. Was a gal who had her tonsils removed and she was bleeding extremely bad. We ended up taking her back to get cauterized, but remember, non-moving blood coagulates and clots. So when we're walking her down this apartment stairs, because of course there's that narrow stairwell there. We got to the bottom and she's like, hold on. And then she spit. And I swear she spit her tongue on the ground. It was such a big clot. I was like, what is wrong? And then sure enough, it was a big old blood clot. And that's when it was like, we can nebulize TXA. Like that was, and it worked like a charm.
Really?
Yeah, it worked super, super well. It was just one of those of like when they were talking about it in the training, I'm like, that doesn't happen. It does. I was wrong.
For those of you listening that don't know, TXA is a medication that fairly new. When I went through my medic program, we were trialing it. Like the place I worked was doing a trial of it that is for bleeding. So we'll give it IV to help with bleeding, but apparently you can nebulize it too.
Tranexamic acid. Yeah. It's the opposite of TPA, which is used for clot busting, which we'll come back to maybe one day.
Yeah, I had a tonsillectomy one too. And it was just funny. Like we get there and it's like, mom and dad lead us up and it's, I don't know, high school age girl. And she's just laying on the floor in her bedroom upstairs and she's super sweet and nice talking to us. And she was like, yeah, I was trying to like get up and go downstairs to get a drink of water or something. And I don't know what happened. I just found myself on the floor. Like she passed out and we're like, okay, cool, whatever. And, so we're like, okay, let's get you up there. And of course it's like, young, handsome fire crew, like kind of the younger guys. And so it made her day because she goes to stand up and one of the like young firefighters is there and she like legitimately starts to pass out. Like you can see the color drains and she like starts to close her eyes. So he like scoops her up and then he like just carried her down the stairs. And you could tell it was like, this is a dream come true for this girl. She was so excited to have the good looking young fireman like carrying her in his arms. And it was cool. It was it wasn't cool. It sucked for her, but like you can tell she was enjoying the best of a bad situation as we like went to the hospital. And she had just been massively bleeding from a tonsillectomy.
We're just green with envy. No one carries you like that anymore.
I know. I wanted handsome firemen to carry me too.
Maybe one day.
I know. Yeah, maybe one day. I just need to go get my tonsils removed.
Yeah.
That's it.
Now you're on to something.
Now I'm gonna call my doctor after this and be like, hey, can we make this happen, please?
I don't need it, but I want it.
I want it, please. So for nosebleeds, realistically, there's not a lot that we can do. What we all probably heard from our mom and dad was like, put your nose up and like pinch it. And like, that's not what we want to do. Cause that just makes us swallow a lot of blood and we vomit it and it's not good. So, realistically, what we want to do is have patients sit forward, put a basin or something that they can drain into and pinch their nose. You can put a little cold pack on their nose too to help with that vasoconstriction and go to the hospital. There's
Might
not much
even have
we can
nose clamps
do.
too.
I never used them. I didn't think they really worked.
I never used them either. When I was a kid, I used to get bloody noses all the time, and my mom told me pinch the nostrils closed and lean forward. And after a while, you wait like 10, 15 minutes or whatever, that blood will clot, and then when you blow your nose, which is so counterintuitive, but that remaining clot would stay in and block the bleeder, but he would be able to breathe again, and it worked like a charm.
Maybe I need to try that. Yeah, my son bleeds all the time. He's just learned. He just goes in the bathroom and does the thing with the toilet paper. But that might be a little easier.
Worth a shot.
Yeah,
It worked.
Try it out. I think that's about it. Anything you want to add on top of what we said about bleeding?
Yeah. Blood is an irritant. So if you swallow blood, you will start throwing up. I did that when I was in 6th grade in math class. I started bleeding and I didn't want to get up because I was embarrassed to have a bloody nose like an idiot. And so I just sat there and swallowed. And then I proceeded to spend the next hour puking up blood. And if you've had a bloody nose like that and you didn't puke blood, you didn't drink enough of it, you coward.
It's such a 6th grade thing to be like, I don't want to get up because people will think about it. As you're over there, you know what I mean? Like every 3 seconds.
Yeah, way more subtle. Okay.
People are already looking at you.
Yeah, who would have thought about it?
Yeah, 6th graders they don't make the best decisions all the time.
Except for me.
Except you made the best decisions for sure.
Yeah, definitely. Cool. Yeah, that's all I got.
Right on. Cool. Well, hopefully that was helpful for you. Thanks for following along, hanging out with us.
Yeah.
Hit subscribe. Follow the podcast, Apple Podcasts, whatever you're listening to. Check us out on YouTube. If you're listening to the audio only version, we've got a whole ton of stuff on YouTube. Thanks. We will talk to you again later. Can't do finger guns
I know.
in an audio only podcast.
Yeah. Watch the video.